And just enlarging that very slightly. And there's our 2.4 millimeter entry. And feel a little sting for a few seconds there. Intraocular lidocaine. So we have a mid-dilated pupil in a male, so you wonder about floppy iris. Almost certainly have some here. So I'm put a lot of visco deep in the chamber and enlarge the pupil. And then next going to make a little opening here in the anterior capsule. Put a little Provisc in there. And we'll do our capsulorhexis. Aiming for somewhere around 4.5 millimeters. Anywhere from, even 4.2 to 4.8, what I consider to be ideal. Okie doke. Hydrodissection with the flat 23 gauge cannula, and I always lift up. That gets you into the cortical cleaving plane on each side. And then 180 degrees of viscodissection. So we'll now check out infusion sleeve position. It's not high enough, so we'll just rotate it to expose more tip. And then check out infusion flow until both sides show good flow like that. So now we're ready to place the chopper there, insert the phaco tip. And the first thing we want to do is get a good view. So we aspirate cortex, and then we're ready to begin our sculpt. And as you aspirate cortex, you might even get down to see the Y suture sometimes. It's a fairly soft nucleus and went kind of right into some nucleus removal there. Wet cornea. As soon as the little light reflexes look a little unsharp, time to wet the cornea. So I just divided. I haven't used any ultrasound yet, of course. Quadrant removal. And may not need any. Certainly don't need any to divide this nucleus. Most patients in their 60s don't require ultrasound, and many patients in their 70s and even occasionally 80s don't require it. So now we're ready to remove each quadrant. Now I could aspirate this whole lens, as you can see, but if I put in little bursts of ultrasound, it'll speed up the process. So we'll use some ultrasound. Patient's age?
It's 68.
And this patient happens to be 68 years old. And of course, it's the high vacuum that allows you to limit the amount of ultrasound that you actually use. Because once the port gets occluded like that, either you'll aspirate a lot of lens material, as I am there, or if you happen to burst, like I just did there, you'll remove more lens material per burst with high vacuum. So now for cortex removal, same thing. There's no infusion right now, so that sleeve certainly needed to be adjusted, and now it's fine. There's epinucleus there and cortex over there. So I'm going to go in and I'm going to use a spatula PRN to protect the posterior capsule. I usually just put it in right at the beginning. Wet the cornea. Good. So you can see the spatula, those of you watching in 3D, is posterior to the INA tip. And so the posterior capsule is always protected when you're doing that. Now, where I'm not subincisional, I don't need to protect the posterior capsule. So now all we need to do here is remove about 180 degrees of epithelium from under the anterior capsule, and we're ready to put in our trifocal intraocular lens. The trifocal that we're using here is the Panoptix lens, which that's my design and patent. I have no financial interest in it, but we use quite a lot of them nowadays for patients who want to have those three primary foci, namely distance and then around 60 centimeters and 40 centimeters, which is about 24 inches and 16 inches of intermediate and near best focus. Okay, so here goes our Panoptix intraocular lens inserted into the capsular sac. And we'll be setting, it's a toric lens, we'll be setting it at 20 degrees. And those of you familiar with seeing diffractive optics will notice when you use this lens that the diffractive pattern looks different. It fluctuates so that each diffractive line doesn't look the same. Some are lighter than others. And that's because the diffractive optics here, I created them to alternate distance, intermediate, near, distance, intermediate, near, etc. So that regardless of pupil size, the proportion of light going to each of the three primary foci will proportionally remain the same. So it really is pupil independent. And that's an important thing because, pupil size varies just like patient's height, eye color, and everything else. So I just lined it up at 20 degrees. And before I do anything else, I'm going to do stromal hydration. And also hydrate the secondary or side port incision. And then very important, always at the end of these cases, I want to go around and irrigate the angle. Two reasons to do that. Get the OVD out so you reduce your chances of a pressure spike. And in case there are any epinuclear and nuclear particles in that location, you get them out. Alright, so I like that location right at that 20 degree axis, just a little parallel to it, that's just fine. IOP is a little high, so I just lowered it to normal level. And that's the trifocal intraocular lens toric variety.